Hello and welcome. I'm Dr. Helena Dunbar. I'm Associate Professor in the School of Nursing and Midwifery. Thank you for joining us for today's event, which marks World Hospice and Palliative Care Day, which takes place actually this Saturday. This event is part of a series of talks scheduled around International Awareness Days, reflecting on research and, of course, the COVID-19 crisis. World Hospice and Palliative Care Day is a day to bring people together to celebrate and support hospice and palliative care around the world. It's a day when many people come together to remember personally those whom they've lost due to a life-limiting illness or a loved one whom they're still caring for. Palliative care focuses on enhancing quality of life for patients and embracing physical, emotional, social, spiritual elements, and managing care through distressing symptoms during periods of short breaks and care through death and bereavement. And for families where there are children with life-limiting illnesses, this care and support is available right from diagnosis, but can go on in some cases for a very long time, even through transition into adulthood. The modern-day hospice movement came into being in 1967 when Dame Cicely Saunders founded St Christopher House in London. Helen House was the first children's hospice which opened in Oxford in 1982. There are now approximately 170 adult hospices and 54 children's hospices across the UK, providing palliative care for over 200,000 adults and children with life-limiting conditions each year in the UK, and a further 70,000 people receiving bereavement support from hospices also. I'm joined today by Dr. Andy Northcote, who's a Senior Lecturer in Medical Sociology, and Sarah Oakley, who's one of our PhD students. Andy's research interests focus on understanding the everyday culture of hospitals and ward settings and how this can affect policy and practice. And today he's going to talk to us about the experiences of older people and people living with dementia during acute hospital admissions. Sarah completed her children's nurse training at De Montfort 3 years ago, and she's now come back and is in the second year of her PhD study, looking at how parents of children with complex needs access support for themselves. Following the presentations today, there'll be a short question and answer session, so please feel free to leave your questions in the chat at any point during this event. If you can't see the chat function, then simply just click on the stream chat button and that will open it up for you. So without further ado, I'd like to start the first talk today, which is titled Parents' Experiences of Identity and Belongingness at a Children's Hospice. Can I have the slides, please? So what I'll be talking to you about today forms part of my PhD studentship, which I completed a few years ago, which was supported by De Montfort University and Rainbow's Hospice for Children and Young People here in the East Midlands. This was a two-phased qualitative grounded theory study exploring parents' perceptions, experiences, and the decisions that they made to access hospice care or not. Many different places, from coffee shops to recreation centres, from hospitals to home, have been shown in the literature to play a valuable role in people's lives. These are some of the places that hold special thoughts for me. You'll see the beach up there is where I grew up, in a place called Portrush in Northern Ireland. Underneath that is the North Shore of Vancouver, where I have been several times and really enjoy being there. And then I had the pleasure of spending some time on a catamaran a few years ago, and decided that I really liked the sea. So places have meanings for us as individuals. They hold memories, good and bad, and we associate place with lots of different uses. But the whole idea of place is a complex phenomenon which draws on the ideas of identity, belongingness, and attachment. Now, place identity is a core component of place, and it refers to the bonds that people form or do not form with a place. And it's achieved as people form thoughts, feelings, attitudes, memories, and behaviours regarding a specific place that they're aware of or have been to. And it's also concerned with the notion of belongingness. Now, the need to belong is a powerful motivator for us as human beings. And whilst abstract knowledge about a place can be acquired quickly, the emotional attachment and feel of a place can take a lot longer to achieve. This emotional attachment to a place originates from the notion of whether a place is perceived as safe or a threat. In his seminal work, Ralph described this ability to feel a sense of belongingness in terms of insideness and outsideness. And he suggested that if you feel you belong and can identify with the place, you will experience a sense of insideness. The opposite obviously happens when a person experiences negativity towards a place, and then therefore that sense of not belonging. Again, we know from the literature that people deprived of belonging experience physical health problems, decreased well-being, sadness, and a feeling of longing. For many of us, the place we identify and associate most strongly with is home. Unfortunately, that's not my home, either of those pictures, but those are my 3 children quite a few years ago. Home is most often described positively as a comfortable place, a secure place, a place of shelter, somewhere that's familiar, a place that we define by rituals and routines, and a place where we very much, on the whole, feel that we belong. In the last few years, there's been an increasing focus on children and place, looking at how children negotiate places like school and the attachment they make to key places that figure in their lives. When we consider children with complex needs, children with life-limiting conditions, children with palliative care needs, place becomes vitally important. We know that for many parents, caring for the complex needs of their child is a 24/7 responsibility within the home setting. Sometimes caring for their child can place an enormous strain on parents, and so parents do begin to consider the need for help and maybe some respite. The provision of short breaks by some hospices has helped bridge a gap in service provision. Now, prior to the coronavirus lockdown, many children's hospices, alongside the provision of other palliative care services and end-of-life services, provided a number of days a year where families with children with life-limiting conditions could choose to go for some short break respite care. Provision of these services are key to supporting parents' abilities to cope, and something you're going to hear a little bit more about in Sarah's presentation later. However, we do have some evidence that some parents initially perceive children's hospices as purely a place associated with end of life. So why is that? Well, some of it's historical, from when hospice movement began, and many adult hospices were set up to purely provide end-of-life care. But we also know that words are very important, and sometimes they can be confusing, and sometimes they change. And I wonder what many of you think today when you see some of these words on the screen. Palliative care, life-limiting, life-shortening, end-of-life, terminal, respite, short breaks. Sometimes the image created by the word hospice can generate meanings for some parents that make them reluctant to be associated with a hospice and decide that they might not need to use the services there. And they might not like to use that term. And certainly in my research, I found that often parents use different labels to describe where they were going, rather than talk about the word hospice. However, for the majority of the parents in the study that I did, this view changed after a visit to the hospice. And certain characteristics, when they were present, helped to work together to foster a real feeling for the parents that this was the right place for them to be. Now, parents wanted to know that their child was safe and secure. They wanted some kind of familiarity. They wanted consistency of staff caring for their child. They wanted staff who knew and paid attention to details, who maintained routines for them, staff who could identify with them, build a relationship with them and trust. Knowledgeable, trained individuals who understood the nuances of care. An environment that embodied the whole family, that made them feel they had made the right decision to come and use the hospice. However, we know again from the literature that place identity is associated with both positive and negative connotations. And in my study, the negativity was associated with the end-of-life care that was given at the hospice. Now, you'll see in this slide, I've put some pictures up, and the older building there is actually Cannock Place in Vancouver in British Columbia. The newer building is Bluebell Wood in Sheffield, and then below that is the reception area of Rainbow's Hospice here in Loughborough. Now, some parents describe the hospice as a building where it actually masked the real reason for the place. I often look at Cannock Place and think it looks a bit like that Disney princess castle at Disney World. And many of them talked about that there was nothing on the outside that shows what's really inside. Others described two sides, a dual purpose, a flip side. Some even talked about this inner threshold that I've shown in the diagram there, where they actually felt that there was a closed door between where they could go for a short break and respite and end-of-life care. And actually, there was no physical differentiation of space within the hospice building. So there's a real paradox here, isn't there? You know, whilst the initial identity of the place represents something that parents fear and perhaps a reminder of their child's diagnosis, I found that there was something about the hospice and its ability to feel like home, because it was a safe environment, that it was able to draw people in and it helped them feel that they belonged. Or some might argue it's a case of self-preservation, a coping mechanism to view the hospice in a different way, so that parents were able to perhaps leave their child there and have some time on their own. But what we do know is that the physical environment will play a role in parents' perceptions. You know, for all of us visiting places, first impressions last, and it often affects our decision making of whether we stay, whether we go, or whether we come back again. Getting families across the threshold is the first step to helping parents see that their child can be cared for in the way that they want them to. In many ways, I guess it's a little bit easier to enter that short break side of the hospice first. Later this year, I'm hoping to travel to further explore some of these questions. I was awarded a 5-week fellowship with the Winston Churchill Memorial Trust, and I hope to return to Canada and travel through Quebec, Ontario, Alberta, and British Columbia. Of course, COVID-19 put paid to those travel plans, but hopefully sometime in 2021 I'll be able to do that. And I hope to visit children's children's hospitals, and children's hospices, and also universities to look at palliative care provision, to look at education and training, and actually really explore the geography of the palliative care place. So in conclusion, there are many positive psychological and well-being benefits of becoming attached to a place, of bonding. However, for many families, to get short breaks is only a temporary situation. And during this pandemic, many places have continued to support families virtually. But the reality is that those services that many hospices offered prior to lockdown for many children have now been suspended during the pandemic period. And therefore, the provision of short breaks for families is diminishing. We also know that there are increasing numbers of families with palliative care needs living in this country who need support. But the worry is there going to be enough money? We know that many children's hospices have lost valuable time to fundraise during this period of the pandemic. The humanisation of care spaces such as a hospice allows connection and belongingness to develop. And in my study, the connectedness the parents had with the hospice grew as their views and perception of it changed. And as they interacted with it more, it became a place where they wanted to go again and again, and a place they missed when they were not there. So from my study, many parents really understood that concept of bonding at a children's hospice. Thank you very much. I've just given you some references there. So now it gives me great pleasure to move on to our second speaker this lunchtime, who is Dr. Andy Northcote. Thanks, Andy.
Hi, thanks for that, Helena. That's really interesting. So yeah, my name's Dr. Andy Northcote, and once my slides come up, I'm going to talk to you about the experiences of people living with dementia during an acute hospital admission. So if we can go on to the next slide. So yeah, so today I'm going to talk to you. I have 10 minutes to try and tell you about 5 years of research. So my research is funded by the UK Department of Health, so it's government-funded research via the National Institute of Healthcare Research. And over the last 5 years, myself and my colleague Katie Featherstone at Cardiff University have been awarded just shy of £1 million to investigate the care of people with dementia during hospital admissions, looking at very everyday elements of care in very everyday hospitals. So not looking at we weren't looking for best practice in shiny new specialist wards. We weren't looking for places that were in special measures. This was just the mundane, everyday reality of hospital care. So if we can go on to the next slide. So in total, to do this, since March 2015, we have spent time on 16 wards in 8 hospitals across England and Wales, observing just shy of a full calendar year, 360 shifts in which we've done observational field work in trauma and orthopaedic and medical assessment units, so key acute sites within the hospitals. And from that, we've collected a hideous amount of data. So over 1 million words of field notes, 20 case studies, and over 800 ethnographic interviews with nurses, people living with dementia in the hospital, their families, carers, and other people involved in hospitals that get forgotten about. So the porters, the kitchen porters, the security guards, as well as doctors and consultants, but really looking at that kind of ground level of care. So if we could go on to the next slide. And what we were looking at is this, that hospitals, NHS hospitals, estimate that people living with dementia are one of, if not the largest patient population in the acute care setting. And they occupy between 25 to 50% of NHS acute care beds at any given time. Now that in and of itself isn't problematic. Could we go back to the previous slide? So that in and of itself isn't problematic because older people generally are more susceptible to hospital admission. They're susceptible to falls, infections, UTIs, retention, a whole host of things, especially if they're living with comorbidities, and now even more so with COVID-19 and our new age of terrifying pandemics. But people living with dementia are particularly vulnerable with this setting. So we spoke to our PPI group, so a collection of people living with dementia, their carers, family members, and they were terrified of acute hospital admissions, more so than just about anything else. The idea of having to go in for after a fall, after a bruise, after an infection, really scared them, and real anger at what happened there. So we started to look into this, and looking at the literature, we started to find real evidence of kind of systematic poor experiences and health outcomes for this patient group. And we wondered why. And in this statement on the slide, you can see in a way, the occupying between 25 to 50% of beds is an estimate, yet we would normally know how many people have been admitted to hospitals for a certain condition now. It's 2020, we have data on these things, but people aren't admitted to hospital for dementia. They're admitted for the fall, for the infection, for COVID. The dementia is an underlying condition, so it's underreported and therefore not there. So we would find when we approached hospitals and said, we want to observe dementia in your acute wards, they would say, why? We have a dementia ward. Why do you want to look at the acute ward? That's not where dementia is. So it's not quantified. And on top of that, hospitals already feel like they're doing a lot for dementia, because they are. They're doing things through awareness, through forget-me-not signs, through blue butterfly badges, through dementia friends schemes, this is me forms, red trays for food to suggest higher need and dependency, purple slippers is a new one. But this is raising awareness, but it doesn't affect care and how it's delivered. Instead, it kind of supports existing ward cultures in a highly resistant setting. So if we can go on to the next slide, I'm going to very quickly, in the next 5 to 6 minutes, try and go through the findings of our study, and then in line with the theme of today's presentation, look at how this influences palliative care in the acute settings, and then very quickly discuss the impact of COVID-19. So if we could go on to the next slide. So the key finding of our studies, the main takeaway, was that the organisation of culture of acute wards is at loggerheads with the needs of its largest population. So older people with cognitive impairment and people living with dementia, because dementia is a very loose diagnosis in the acute setting. It gets mixed up with delirium, with confusion, or it may only be spotted as a result of the admitting condition and then diagnosed afterwards. So if we could go on to the next slide. What we found was that the needs of the wards are incredibly complex mechanisms that rely on processes to work. So a medical assessment unit, for example, it requires to stick to very strict timetables all day. It needs to get empty beds so that accident and emergency can get people from A&E into a bed to be stabilised, and then they need to move people from the unit onto wards. So those wards need to get beds through. So the hospital's in this constant motion of flow. Everything needs to be done at the right time for other things to happen, for doctors' rounds to be able to be done, for medication. And it's like this terrifying machine. And if something doesn't fit in that machine, it creates issues. And people living with dementia don't follow those rules and timetables. Dementia is incredibly personal, idiosyncratic, and complex. So what we find is that we have ward staff, nurses, healthcare assistants, and this is no way nurse bashing, that's the last thing we'd want to do, lack the time and the resources, not the ability because they want to care, but they're not able to provide the complex care that's needed, and instead fall back on kind of compulsive repetition and communication of the rules of the wards, what people can and can't do. A sort of reorientation to where a person is and the needs of it. So you're in the hospital, you must stay there, the doctor will come and see you, you must eat that, you must take this. And instructions for the patients to stay in the bed or at their bedside, to minimise the risk of falls, patients getting lost, and just so staff know where people are when it comes to delivering aspects of everyday care. To get the next slide. Because of the limited resources and what people can do, there's this key focus on verbal communication, telling people what they can and more often what they cannot do, so that they can fit these routines, these timetables, the needs of the ward rather than the needs of the person. And this can be particularly visible when it comes to sort of not just what someone's doing, but how they do it. Things need to be done in the correct way. Meals need to be eaten at the correct time, in the correct way, at the correct speed. You can't spill food, the correct clothing must be worn. And because of this need for kind of cleanliness and for the ward, things like personal possessions are stripped away. So the things that somebody might have at home to calm them down, to refamiliarize themselves, are taken away. Ladies are without their handbags, men are without razors and watches and things that they rely on to reorientate themselves, to know what time it is, to know where they are. And instead they're just told, you're in the hospital, you must sit down, you must stay in bed, you can't do this, you can't take that, you can't go there. So if we could get the next slide. So in a way, this demonstrates the understandings of dementia, but more importantly, it's kind of a return to the doctor's orders of an old school hospital of the 50s and 60s, where matron knows best and you must do what matron says. And as people are constantly told what they can do or what they can't do, that they can't get up and walk around, that they can't go to the toilet, that they must eat this bit of food that they don't like, people with dementia, people with cognitive impairment get annoyed. And this annoyance comes out in sort of agitation, aggression, trying to get away from the ward. And these quite rational actions become medicalised. So trying to get up and walk away is wandering, something that must be stopped. Saying no to medication is refusal of care. And this leads to the patient being further and further contained, restricted at the bedside, restrained. There might be security guards involved, which creates cycles which further disrupt the timetable of the ward, which must then be corrected and further upset the patient. Can I get the next slide? I'm trying to do them myself and that obviously doesn't work. So the acute ward doesn't fit people with dementia. They don't belong there. And you could say the same about palliative care. People aren't meant to die in the acute care setting. We have within the NHS, and it's not my area of expertise, but within the hospice care and palliative care, comfortable ways to die. And we all want that kind of Hollywood death where you're in a bed with some flowers around it and all your family holding your hands as you drift off into a comfortable sleep. But unfortunately, that's not the reality of what happens. And people are regularly admitted to acute care wards, specifically to medical assessment units, because they've started to decline in a care home or at home. And even though someone may have said they want to die at home, they might have do not resuscitation orders, advanced care planning, living wills. People panic at times of death. People don't want someone to die. They want to do something about it, or they don't want to be litigated for it. So they send the person to hospital. And that means that what a lot of end-of-life care in acute wards ends up being is trying to find a side room where a patient can be private and with some dignity. There'll be some flowers stuck on the door so nurses know not to disturb them. And the end-of-life palliative care at that stage is very much just making the patient comfortable, which is an awkward euphemism for fill them with morphine and close the door and try and keep things quiet around there. So if we can move on to the next slide. So how does this fit with COVID-19? And if we can get the next slide again, we don't really know, because at the moment, I can't go and do any research. I'm not a nurse, I'm not a doctor, so they're keeping me well away from hospitals. I'd be an infection risk, I'd be a nuisance, so we don't know. But what we do know is it's harder to get into an acute ward at the moment. GPs are limited in who they can refer into units because of certain conditions. And we also don't know how people are getting out of them, because while there is much clearer policy now than there was 6 months ago on how you discharge someone back to a care home, back into the community, that doesn't necessarily reflect practice, because policy implementation in wards is a hugely complex issue. We also don't know how things like PPE and social distancing are affecting people with dementia. The idea of being approached by someone wearing a mask, a face guard, and the full terrifying hazmat suit is going to be further disorientating, especially if they're just saying you're in the hospital over and over again. And because of social distancing, standing 2 meters back at all time. And what we suspect as a result of this, and with the infection risk, is that I have no evidence for this, and we're hoping to find that, is we fear a further culture of restraint, the need to keep people at the bedside because of infection risk and because social distancing is hard to explain to someone who doesn't really understand where they are. And a big worry is that this will, within the new normal, become a more ingrained, established part of ward culture. And that's what we're hoping to look at in my next research project, hopefully in the next 12 months or so, when we can get back onto the wards. Can I get to the next slide? I'm out of time, so if anyone wants more details, my book is published next month and is open access, so you can get it free if anybody wants to read it through the Routledge website. And the next slide, And you can email me any questions you might have, follow me on Twitter, or check my website for more details on all the studies we're doing. That's the end of my presentation. So without further ado, because I've probably overran there, I'd like to pass you on to my colleague, Sarah, who is going to talk to you about children with complex medical conditions. Over to you, Sarah.
Hello, thanks, Andy. Thank you, Andy and Helena, for your really interesting presentations. My name's Sarah. I am a children's nurse from Birmingham Children's Hospital, and I'm a PhD student here at DMU. And my presentation today is going to be about my PhD project, exploring how parents of children with life-limiting conditions seek and access support for their own well-being. So if we pop my slides up, and if we go on to the next slide, I'm just going to give you a brief background of what children with life-limiting conditions experience day to day. So what is a life-limiting condition? So a life-limiting condition is a condition where a child's life expectancy is unpredictable or is shortened due to their diagnosis. And some children remain undiagnosed for the period of their lives too. A recent study's come out this year by the lovely Lorna Fraser that estimates there are up to 86,000 children in England with life-limiting conditions. So we're talking quite large numbers here. Living with a complex medical condition or a life-limiting condition can involve around-the-clock 24/7 care, and these care needs can involve things like being tube-fed day and night, multiple medications throughout the day, mobility needs, for example, requiring hoisting or wheelchairs, also technical equipment such as ventilators and suction machines that keep these children alive and healthy. And there's a lot of responsibility that comes with caring for a child with a life-limiting condition. And this responsibility is namely down to the parents. And where previously in sort of the 80s, 90s, these children would have a life that's lived in the hospital, these children are now looked after at home and receiving often 24/7 care by their parents. This can cause a lot of parental strain. The research has shown that these parents experience stress, exhaustion, depression, social isolation, and can be a really difficult task. But parents continue to look after their children in a really diligent and compassionate way. If we go on to the next slide, if we look at what support do parents get at the moment with these caregiving duties, as we're coming up to World Hospice and Palliative Care Day, it would be wrong not to mention the value of children's hospices. And Helena did go into some more depth about the value of children's hospices, but they do a really valuable job of supporting parents with their caregiving. And some of this support includes things like giving them a short break, but also includes support groups for parents and some practical advice and information, as well as end-of-life care and bereavement support. Parents are also supported through the NHS, as you can imagine. A lot of children with life-limiting conditions are diagnosed in the acute setting, so in hospitals. And it's often there that a huge team of specialists is built around the child and the family. And some families have more than 10 professionals and specialists involved in their care. Continuing healthcare is also a big source of support for parents. So for those of you that might not know, continuing healthcare provides a package of support for families to enable them to continue caregiving and looking after their child at home. So depending upon the child's needs, for example, a carer might come into the family home every day or every night, and for some children it is 24/7, and take on the caring duties either alongside parents or whilst parents are doing other things. Charities are also really valuable for parents, and obviously I can't go into all the charities that support parents here, but there are a lot of specific um, diagnosis-specific charities that are really helpful in providing advice and information to parents. Yeah, even with all these types of support, and there are more. Obviously, family and friends can be a huge support to parents. Even with all this support, the research shows that parents still experience negative health and social impacts as a direct result of their caring responsibilities, which just isn't good enough. If we move on to the next slide. I'd like to talk about my research project a little bit now in the time that we have remaining. So my PhD research project is aiming to fill the gap really for what we've just discussed. So my study is exploring how parents of children with life-limiting conditions seek and access support for themselves. So really it's looking at how are parents experiencing support on a daily basis, what's working well for them and what's not working so well. And this is so that we can really plan services to effectively promote parental well-being and ensure that they're not, they're not as stressed and anxious and isolated as the research shows. So my research project is a grounded theory study, taking into consideration the experiences of parents, but also the organisations that support parents. So, for example, charities, schools, and also the nurses and care staff on the ground, both qualified and unqualified. And this study interviews all of these staff and parents and families, so we can really understand what support parents are experiencing in their day-to-day lives. If we pop onto the next slide. Here we are. So compared to Helena and Andy's study, with their firm findings, we're still at the really early stages of data collection for this study. But we have found some really interesting findings to begin with. So the palliative care nurses that have been interviewed so far have discussed COVID-19 as a really high priority, as you can imagine. And COVID-19 has really changed the way parents are receiving support for themselves and for their own well-being. So the nurses have told us in this study that lots of families that have chosen to shield or that are forced to shield are receiving very little face-to-face contact, and all of their, or a large majority of their support is coming via the phone or via Skype and Zoom and teleconferencing. And this can be worrying to some extent, where families might not be able to be as open about how they're feeling and the stresses that they're experiencing at home. And nurses need to be really careful that we're still able to pick up families that are struggling to ensure that we're avoiding crisis for these families. Also, for these parents, the shielding is as much to protect themselves as well as to protect the child. So, of course, if a child with a complex medical condition contracts coronavirus, the effects can be devastating. But also, parents are concerned that if they were to contract the virus, then who would look after their child, and who is as specialised and has as much knowledge about their child as they do? And oftentimes the answer is there is no one. Other findings have revolved around care inside the family home and how professionals and parents navigate the relationships being inside the family home. So previous research has shown that some family homes feel more like clinics with all the medical equipment and the amount of professionals that are constantly in and out the family home. And this is something that the nurses are very aware of. And the ability to make families feel like they're not being watched or judged all the time is something to be aware of. But also within the family home, parents can be really well supported when the relationships between the nurse and the family are strong and secure. And nurses have told really positive stories about the relationships they have with parents and how they feel like one of the family, and how they've been present in birthday parties and family events. And they really feel like part of the child's and the parents' family, which is lovely. So if we just go on to the final slide, the future of this study. So at the moment, like I said, we're still at the early stages of data collection. But if you think you might be somebody who could be involved in this study, if you work in children's palliative care, whether you're qualified or unqualified, or if you are a parent or a family member of a child with a life-limiting condition, then it would be really great to hear your experiences. So on this slide, I've just popped my email address and phone number. If you would like to be involved, then do get in touch. And finally, on this slide, I've also popped the names of 3 charities: Together for Short Lives, Acorns Children's Hospice, and Rainbows Children's Hospice. These are 3 charities that do an amazing job supporting families of children with complex care needs. I challenge you today to visit one of these websites if you haven't done so before, and just learn one new fact about the lives of families with complex needs, in order that you might be able to support a family if you meet them in your day-to-day lives. So that's all from me from this presentation. Thank you all for listening, and like I said, get in touch if you have any questions, and I'll pass us back to Helena, if that's okay.
Thank you, Sarah. That was really interesting, and I'm certainly looking forward to your data analysis and the findings from the study. I just wonder whether, Sarah, you've got any sort of evidence of, you talked there about how you felt that COVID was affecting the families at the minute. I wonder whether, have any of the professionals talked about how it's sort of affecting them also, in delivering that care?
Yeah, definitely. I think COVID-19 has obviously made professionals have to adapt in the way they work and work in different and new ways, which initially has been uncomfortable for some of the nurses, like I'm sure it has for all of us, in terms of getting to know new technologies and being able to deliver the same types of care that they normally would in person, but dealing with the technical issues and varying internet and things like that.
Yeah.
And I think as well, for some of the nurses and professionals, it can be difficult to maintain those strong bonds and really ascertain how parents are feeling, when it's over the phone. And when you can't read facial expressions and things like that, it can be hard to pick up if parents are struggling or so yeah, it's been tough for professionals as well.
Yeah. Andy, would you like to come in on some of that? I was just thinking, your study, absolutely colossal size piece of research, which is phenomenal. But one of the things I've found over the years is that we do a lot of service improvement, a lot of research studies, but actually implementing the recommendations for practice and making a real difference with policy and practice. So for you, Andy, sort of what's your plans around really sort of affecting policy change for people with dementia?
That's what we found really difficult with our research. And I came through this, I'd done a bit of research in children's hospitals before I went into dementia, but it was my first time sort of the big acute wards. And after the first study, we thought we'd sort of solved everything and we'd struck gold, and we knew exactly the ways that all these wards could do these tiny little things that weren't going to cost a lot of money. And we did a feasibility study, and the staff went, that sounds lovely, when are we getting the time to do that? And we hit this kind of constant resistance within the wards have to work in the way they do, otherwise everything falls to bits, and nurses have 100 plates spinning at once, and adding another plate means 10 others fall over. And yeah, it would be lovely if they could sit and have a chat with the distressed patient with dementia for 5 minutes, and it would solve a lot of issues, but not if somebody has a heart attack in side room 2 while they're doing it, so they need to keep checking side room 2 and writing their measures down. And it was funny when we came to writing the book I mentioned earlier. I'm not just promoting my book, it's got we went back to kind of the old 50s, 60s hospital ethnographies, so Menzies Leaf and things, looking at nursing practice then. And you could see the patterns there, that certain established things in nursing really are resistant to change, not just nurses as well, just within medical practice. So you do have all these policies, and dementia's been quite a prominent thing for about 10 years now. And I've got a lot of criticism of the David Cameron government, but they did put a spotlight on dementia in terms of funding and action. And it doesn't necessarily result in change at a ward level, because even wards that do try and change stuff, if they change stuff and it means that transfers are affected, or they can't take as many patients, or their falls go up ever so slightly, they'll quickly get rid of those, because that's what's quantified in the hospital. And so the banging against the wall quite a lot of the time, but it's we're working on it.
Yeah, I think we've seen similar findings with sort of palliative care, really, and implementing many of the valuable resources and strategies that are out there, and making a real difference in practice. And it's a bit of a postcode lottery, really, in terms of what's happening. I was really interested in one of the comments you made, Andy, was palliative care does not belong in the acute care setting, because obviously that's where many adults are dying. So from my point of view, it's very much part of the acute care setting, because that's all we have at the moment. So I find that quite an interesting statement.
I'm possibly might be a kind of sweeping statement I tell an undergraduate off for in an essay, but it does have that kind of feel that we know there's the resources there and that research is, but they're not accessible, especially on a unit, so a medical assessment unit, so I spend most of my time. Because it's a unit and a place of transit, essentially, it's a patient flow in the hospital. Out, those resources aren't available in the same way they're not for dementia, and in paediatric things as well, if you're still in that kind of triage stage. But people do die in those places, but the resources aren't there, and it's not an ideal situation. And you do occasionally see that awful thing of like a bay of 6 patients, and the curtains are drawn and someone's crying on the other side for what's happened. And you can tell the staff get upset. It's every day, but it's still, because it's not that place. It's a big event as and when it happens, and it's
Yeah, I think it'd be really interesting, Sarah, with your study to see sort of we'll really get, I think, some findings about the impact of COVID on many of these parents, really, because we can sort of anticipate some of that. But as I said, things are changing. Hospices aren't able to offer the same kind of services that they have been, and yet for many parents, that's where they were getting much of their help from. So I think it's going to be really interesting, some of the work that you're going to be looking at in terms of support Are you getting any kind of feeling? I know you've not actually spoken to parents yet, but sort of, are you getting any kind of feeling from the professionals that you've talked about their concerns regarding where parents can actually get support from?
Yeah, certainly. So like you mentioned, if parents are used to having, respite breaks, whether it be a weekend break or even just an evening off every now and again, a lot of those mechanisms just aren't in place anymore. And similar with the continuing healthcare, and some parents have rejected having carers in the house at all. So that means that parents are doing 24/7 care, and have been for some families since January, February time, and might not have had a single piece of help practically with meeting the needs of their child. And that's something that parents are just becoming absolutely exhausted. And if those respite opportunities aren't opened up, soon, then
Yeah,
I think there really is a concern that parents will eventually burn out. And
yeah.
I think, like I mentioned, if if the parents can't look after the children at home, then oftentimes there isn't somebody that's fully trained to meet all of the child's care needs. Um, it's not always as maybe simple as bringing the child to a family or friend's house, because people don't have the training that's required.
Yeah, yeah. I think, Andy, while you were talking, I was getting little flickers of things that were very similar in some of the things that I found when looking at that whole sort of place attachment theory. And you talked about familiarity and taking things away, and that's our sort of consistency. And again, that was, although we're at different age spectrums, to some extent, many parents were saying the same thing to me, and that whole concept of attaching to an area, no matter where it is there seem to be some similarities there. I don't know whether you were getting any of that.
Yeah, well, before I started this project, I was very briefly on an ethnography at Sheffield Children's Hospital, and it's funny, you get quite similar things. So with the patients with dementia, you have the carers, the family members, and that big kind of guilt. Do they have to be at the bedside? Do they have to be there caring? Can they go home? And it was exactly the same stuff we're getting from parents from children in a similar situation. Do they need to be at the bedside? Are they being a terrible parent if they go? What about the other child who's at home? And there was these real conversations that are incredibly similar, except there's the generational swap often. So it's predominantly the female, so it's the daughter caring for the parent or the mother caring for, and can they go home? And so the parental respite stuff's incredibly similar to the carer's respite that we see, and these tremendous feelings of guilt and pressure and expertise and attachment.
There have been some positives. I hope you don't mind me jumping in. In our study, with obviously some of the carers and parents have been furloughed. That's meant that within some households, both parents have been resident at home for the last few months, which has helped in some households, where previously, like you say, you might have had the mum doing the 24/7 care, and the dad perhaps going out to work to earn the money. If the dad's now been furloughed and can spend more time at the family home, that has been seen in some cases to be really positive, with the dad being able to take on half of the caring responsibility, and have give the other carer a rest, which is obviously a really positive thing as well.
Yeah.
Could I ask one last question if there's nothing in the comments coming in? So Sarah, I'm quite jealous because I'm on like complete research hiatus. I'm just a full-time teacher now because they won't let me awards till this is over. How are you finding doing research during COVID? Have you had to adapt? And is it the same using Zoom and telephones and things?
Oh, so yeah, of course. When I was planning this research project, I assumed that I'd be doing face-to-face research, going into people's homes, which I was really looking forward to. But obviously, COVID's put a kibosh on that, so everything so far has been done via Zoom or telephone, which I think I've adapted to well, and I think so have the other professionals. But positively, it's meant that I've been able to interview staff from Northern Ireland and the south of England that I wouldn't have had access to before, in terms of the time it takes to travel. I wouldn't have been going over to Northern Ireland. So I think the virtual aspect of it might really open up this study and allow parents and professionals from all over the United Kingdom to be able to have a say, which they probably wouldn't have been able to with the way the study was formatted previously.
Yeah.
Cool.
Yeah. I think it's great, isn't it? The opportunities like this for us to sort of recognise that actually there's similar work going on, and actually opportunities to sort of work together, perhaps in the future. I know with your work, Sarah, myself and Tanya Hart from De Montfort have just also received some funding to look at siblings and their support and their welfare and resiliency. So lots of things happening around sort of, in relation to COVID also.
Really valuable. Definitely.
Yeah, absolutely. Okay, I'd just like to say thank you very much to both of you for your time today, and also to the audience for watching and for your comments and questions. We do hope you'll be able to join us in some further events. The next event in this series is actually tomorrow for World Homeless Day. If you'd like to know more about that, then just click on the listing on the screen. So all that's left for me to say, guys, is thank you again for joining us, and have a good rest of the day and stay safe wherever you are. Thank you.
Thank you.